Thank you, Sean, and good evening, everybody. Thank you for taking some time from your evening tonight to join us. Some of you have attended the previous sessions. So these are the weekly webinars during the month of May, being the Brain Tumor Awareness Month. So we share with you some information, some of the things that go on in our minds, some aspects that are related to the clinical practice as well as to research happening on in the field. So for tonight, our focus is going to be on sequencing of tumors and what that means. The title is Decoding Brain Tumors, Insights from Molecular Profiling, and we'll get into that some more in a second. But I'm joined today also with my colleagues, Dr. John Glass and Dr. Nina Martinez. So the three of us are the three neuro-oncologists at Jefferson, and thank you for trusting Jefferson with your care, and we hope to always meet and surpass your expectations as it comes to clinical practice and always being on top of the latest evidence for brain tumor management. So I'll just have Dr. Glass and Dr. Martinez say hello before we start the webinar.
Hi, everybody. It's good to see you. Even though I don't see your pictures, I know you're there.
Yeah, good evening, and thanks for coming.
So we were told that actually our videos may go away as we start the presentation. So just in case, that's what's happening at a technical level. But so I'll go ahead and get started. All right, so again, decoding brain tumors, insights from molecular profiling. So these are some of the updates that are happening recently in the field. And of course, within the crowd that we have today, the variety of brain tumors is pretty vast. So there's a spectrum of brain tumors anywhere from malignant to benign. So some of the things that we're going to discuss today may apply to some of the members of the audience. However, they may not apply to everybody, but we will try to make it relevant to the different subtypes of tumors that we will discuss today. So why molecular profiling, and what does molecular profiling even mean? So every single cell in our body, of course, has DNA. DNA is the kind of the book really for all the cells that tells them what they are and how they should function. DNA is composed of different genes. And again, each of these genes has a function within the cell. So as a lot of you may know, the DNA is composed of this, what we call the double helix, and then the alphabet of the DNA is what we call the nucleotides. And then the DNA is composed of 4 different nucleotides. There's thymine, adenine, cytosine, guanine. And these make the alphabet of the DNA. So as we understand the DNA better, as you heard hear the term sequencing, what that means is that we're able to read this alphabet and we're able to make out these sentences that make out the genes, and then eventually the entire book that makes out the entire, what we call the human genome. So every single cell in the body is under really very tight control. So every single cell in the body goes through what we call the cell cycle. And this is a very well-controlled process in that the cells are given instructions as to when they need to stay dormant and when they need to proliferate and give daughter cells. And this balance is typically achieved because of 2 sets of genes. There are what we call the tumor suppressor genes. So from the name, these are the genes that put the brakes on the cell cycle, tell the cells to slow down, to stop proliferating, not to give daughter cells, as opposed to oncogenes, which are the opposite genes. So this is the gas genes, and these are the genes that tell the cells to go ahead and give daughter cells and proliferate. So this is a very delicate balance usually between in the normal state, where the cell cycle, again, based on the DNA information, based on the instructions that it gets from the DNA, kind of knows when to do what. However, what happens in tumors in general, we call cancer being the disease of the DNA. So what happens is that that delicate balance actually gets out of whack. So that is usually caused by mutations. These mutations can can affect what we call the tumor suppressor genes. So take away the brake from the cells so that they do whatever they want, or these mutations can happen on behalf of what we call the oncogenes. So they drive the cells to proliferate and grow and just get out of control. So what happens is that, again, we have a normal cell. It gets the first hit, what we call the first cell damage, the first mutation. So it gets a little out of control, and then a second damage, a second mutation happens, a third damage, third mutation, and then eventually these mutations just accumulate and the cell is able to get completely out of control. So an easy example that we're all familiar with is in the setting of, say, lung cancer and smoking. And that link has certainly been well established, whereas as exposure to this carcinogen happens over time, finally the cell gets out of control and triggers cancer. Unfortunately, when it comes to brain tumors, we don't have that direct link. We really don't have an agent that we can pinpoint to. We don't have a carcinogen that we can blame for brain tumors, whether they are the benign brain tumors or whether they are the malignant brain tumors. Unfortunately, we still don't understand why some people end up getting brain tumors. And we still think of this as being a random event where, again, one cell, for some reason, whether it's an exposure, whether it's genetic inheritance, and we'll talk about that, finally decides to get out of control and form the cancer. And when we talk about mutations and analyzing mutations in the cells, there are two different types. So whenever the tumor is removed, we analyze the tumor, we do sequencing of the tumor. So that's what we call the cancer genome. So we're looking at mutations inside the tumor cells specifically. And these are what we call somatic mutations. So these are mutations that happen in the cancer cells. They're not present in every single cell in the body. They're just present in the tumor cells, and they are the mutations that trigger the tumor to happen and occur in the first place. On the other hand, when we analyze normal cells, say we analyze the cells from the lining of the mouth, we analyze cells, say, from hair, from blood, from white blood cells, what we find here, what we're testing here is the normal genome that is present in every single cell in the body. So what happens in very rare situations where there is a familial condition that can trigger tumors in multiple generations and multiple family members, what happens is that they actually have a mutation in every single cell in the body. So that's what we refer to as a germline mutation. And these are the mutations that are inherited and cause familial cancer syndromes, syndromes that are carried on in multiple generations that can trigger different tumors, including brain tumors sometimes. But again, these are considered very, very rare. And so again, these are random events that for some reason, unfortunately, occurred in a certain individual that triggered the brain tumor, but it's not something that they can pass on to their children. So when we say sequencing, basically sequencing means reading that alphabet. So that alphabet that we talked about, the 4 nucleotides that make up the DNA, sequencing is this very advanced technologies, very advanced machines that are able to actually read these chemicals within the DNA and read out these different letters and read out these different sentences, and finally give us the information about the different genes and the mutations that are present inside the tumor. So initially we started with sequencing normal cells so that we know what the normal genome should be like, quote unquote, normal. But, and then eventually, as we started sequencing tumors with what is called the Cancer Genome Atlas project that started in the 2000s, finally, we started comparing the genome of the cancer in comparison to the normal genome. And that's when we learned about mutations that trigger tumors and cancer. So throughout your interactions with providers, or sometimes, just reading via the internet or on patient forums, perhaps you've heard about some of these companies such as Foundation Medicine, Caris, Tempus. So these are third entity companies that have made it their business to sequence tumors, to provide information about mutations within these tumors. So in any big academic institution such as Jefferson, we actually do our own molecular panel where we're able to identify the most common mutations that sometimes happen within the brain tumor arena so that we understand the tumors better, but we also always have an option to send the tumor sometimes for a little more comprehensive test, or if we're looking for something specific that the molecular pathologist at Jefferson does not provide us with the information for, sometimes we seek out to send a piece of the tumor to, again, various companies that can do these analysis for us. So why in 2024, it's kind of routine practice for us to sequence a tumor? There are two big reasons. Number one is that we want to reach accurate diagnosis, because accurate diagnosis helps us a lot in prognostication, helps us a lot in understanding what we're exactly dealing with. So in providing counseling for people, for patients who have brain tumors, of course, we want to know exactly what kind of tumor they have and what the best management for specific tumor is. So we've learned over the past 2 decades, we've learned that, again, I'm now talking specifically about gliomas, which may or may not apply to different members of the audience today. But for example, for gliomas, there are the two big categories that we call the astrocytomas and the oligodendrogliomas. The astrocytomas can either have what we call an IDH mutation or be negative, what we call the IDH wild type for that mutation. IDH being an enzyme that helps us actually in metabolism in general, in metabolism of different nutrients. So for some reason, when it gets mutated within certain subtypes of the cells within the brain, it can actually trigger these tumors that we call the IDH mutated astrocytomas. When there is an additional genetic change on top of the IDH mutation, what we call the 1p19q co-deletion, this is what defines a tumor subtype, a glioma subtype that is called an oligodendroglioma. Both in IDH mutated astrocytoma and oligodendroglioma tend to happen in younger patients in general, whereas the IDH wild type or the IDH negative or the IDH normal astrocytoma that does not have the mutation within the IDH, this is more so the bread and butter glioblastoma. Eventually, as it grows in grade from grade 2 to 3 to 4, it reaches that grade, that tumor that we call the glioblastoma. And this tends to happen in older patients. So again, at an academic institution, definitely this is going to be analyzed very thoroughly in order to know exactly what tumor subtype that we're dealing with, and that in turn will lead to kind of the treatment recommendation for the tumor subtype. And again, even though I have here the example for glioma, but for other tumors, for example, meningiomas, which are benign tumors that sometimes happen on behalf of the meninges in the brain, we still kind of that there are different subtypes of meningiomas also related to the different mutations that happen inside the meningiomas. So when talking about the glioblastoma, which is the kind of the more aggressive brain tumor that again happens usually in older adults, another very important molecular marker that we usually test for is this marker called MGMT. So MGMT is an enzyme inside the tumor that tries to fix it from the effect of radiation and chemotherapy, which is the treatment that we usually use for this disease. And when MGMT is methylated, so the gene is methylated, meaning that the gene is silenced. So there isn't a whole lot of this enzyme inside the tumor. We know that this is the more sensitive type of the tumor. So that's the type that responds a little better to treatment. Whereas where the promoter, what we call the promoter of the gene, is unmethylated, so the gene becomes active. So there's a lot of this enzyme within the tumor, and that usually leads to a more resistant type. So this information becomes very relevant, again, as we think about this tumor, as we get surveillance scans, typically every 2 to 3 months for surveillance for these tumors. Whenever we interpret the scan, it's always very important to us to know what the molecular subtype is, because that not only helps us, again, in get into better management, better treatment for patients, but also in understanding that this interpretation of the scans better and what to expect based on what we know about the specific tumor because of its molecular profile. So without getting into a whole lot of details, but that's the concept of sequencing. So not only we're learning about IDH, not only we're learning about MGMT, but we're learning about some other mutations that become relevant, especially when we think about treatment for this disease. So for example, one of the most common changes that happen within the IDH negative glioblastoma is what we call the epidermal growth factor receptor amplification. So from the name, this is a growth factor receptor. So it's a receptor that triggers the cell to grow and proliferate. And then when there are too many or a lot of copies of this gene, so there's amplification of the genes, there's a lot of copies of the gene that can trigger the cells to grow. So EGFR, for example, happens in about 50% of the time in glioblastoma. There are other markers, for example, the platelet-derived growth factor receptor. So that's another growth factor receptor from the name, happens in about 15% of the time in glioblastoma. These both are what we referred to earlier as oncogenes, whereas here too, on the right side, these are related to tumor suppressor genes. So if there are few copies of, let's say, P10 or CDKN2A, few copies of the suppressor, that leads to, again, a lot of growth within the cells. So these are some of the things that we're thinking about as we sequence the tumor. These are some of the things that we're thinking about and we want to find. And again, the number two big reason we want to sequence the tumor is that sometimes it can actually alter treatment decisions. So whether we're thinking about MGMT and response to chemotherapy, specifically the agent that we commonly use that is called temozolomide, sometimes that becomes relevant, or sometimes in seeking clinical trials or counseling patients about a specific clinical trial that they may or may not be eligible for. Nowadays, clinical trials can be very specific in terms of what subtypes of the tumors they want to include in their clinical trial, and that's again based on the molecular profile of the tumor. So again, that's where this becomes relevant because nowadays, for example, we have inhibitors for EGFR, we have inhibitors for PDGFRA, we have some agents that can affect the kind of the tumor suppressor genes and when they're lost and how we can restore some of that function in order to bring the cells closer to the normal cell cycle so that we get out of that uncontrolled growth of the tumor. The reality does become that this is all kind of somewhat oversimplified because glioblastoma specifically has a lot of what we call heterogeneity. So not only we have one marker, but really the cells are composed of or rely on a lot of different markers, rely on a lot of different pathways in order for them to grow. So this has been the challenge, especially again when treating gliomas and glioblastoma, is trying to come up with strategies that perhaps are not only there's no one path fits all. So talking to about the concept of personalized medicine nowadays, we want to understand the tumor better so that we sometimes choose combination strategies that we think might work best for the tumor, again, because of the specific molecular profile. So this was an overview again about sequencing. Now, Dr. Martinez is going to go into more depth specifically about that entity that we discussed earlier, which is the IDH mutated tumors, because of some recent clinical advances in the past year that may apply to a lot of patients in the audience. So I will now hand it over to Dr. Martinez.
Thank you, Dr. Alnahhas. That was great. I noticed there are a couple of questions in the chat, and I think might be better if we leave those questions to the end. I hope you guys don't mind, because we do have some material to get through. So we will address your questions either during the presentation or at the very end. Okay. So to recap, most common types of gliomas that we see are IDH mutant astrocytomas, oligodendrogliomas, which are inherently IDH mutant, but also carry co-deletion of, or actually are characterized by deletion of the small arm of chromosome 1 and the larger arm of chromosome 19, as well as IDH wild-type astrocytomas. Wild-type meaning basically not mutant. As oncologists, we pay special attention to the IDH status because it affects how somebody's tumor will behave. Now, Dr. Alnahhas spoke a little bit about IDH wild-type astrocytomas. As he said, I will focus on the IDH mutant tumors. As he also mentioned earlier, cell damage can lead to changes in DNA, these genetic changes, and these are what we refer to as mutations. Some of those mutations are silent. In other words, they don't affect how the cell normally functions. We probably wouldn't even notice that there's a mutation. And then sometimes they aren't. And the best example of that is when a tumor forms. To understand how these mutations lead to cancer, we first need to know what IDH does normally. So I warn you, I will be taking you back to high school biology, and I promise I will not quiz you on this. Just consider this extra credit, and in my eyes, everybody gets an A+ just for attending. So here's a drawing of how genes are organized within our DNA. So we have the double-stranded helix, bundle them up, and they form chromosomes. There are multiple chromosomes within a cell's nucleus, and then if we organize them, we can set them out chromosomes 1 through 22 and XY genes. Some cells acquire mutations in the IDH1 gene, which is located on chromosome 2, and some cells acquire mutations in the IDH2 gene, which is on chromosome 15. These mutations result in cell changes that lead to cancer. So when needed, the IDH1 and 2 genes serve as instruction manuals for the creation of IDH1 and IDH2 enzymes. IDH1 enzymes float around the cytoplasm, and IDH2 enzymes can be found within the mitochondria, which we all know is the powerhouse of the cell. And we refer to the mitochondria as the powerhouse of the cell because that's where the Krebs cycle takes place. And you probably were hoping that you would never hear the Krebs cycle ever again, but it's important here. And why is it important? It's because it, through a series of biochemical reactions, it converts the energy that's stored in our thighs and our bellies and turns it into active energy that lets us get out of bed and start our day. And IDH is important because it facilitates the production of a biologic compound called alpha-ketoglutarate. And this compound is important in several healthy mechanisms, things like epigenetic regulation, DNA repair, cell metabolism, detoxification of ammonia that gets to the brain. And when the IDH genes are altered, the enzymes that are produced are abnormal and go rogue. So here's the alpha-ketoglutarate, and here are the mutant IDH1 and IDH2 enzymes. Instead of doing what they're supposed to do, they end up increasing the amount of dehydroxyglutarate, or D2HG, by taking the alpha-ketoglutarate that's available and metabolizing it further. And what happens is this D2HG causes a bunch of other problems, such as things that will result in cancer formation, genome-wide CpG island hypermethylation, increased double-stranded DNA breaks, cells that don't die, and this can be a problem. So again, the two types of gliomas associated with IDH mutation are astrocytoma and oligodendroglioma. And with treatment, these are more likely to stabilize or even regress when compared to IDH wild-type glioblastomas. Treatment typically involves a combination of surgery, which physically removes the tumor, radiation, which zaps and kills the tumor cells, and chemotherapy, which will get into the tumor cell and keep the cells from dividing and multiplying. A more aggressive approach, which results in better tumor control, employs all three, but it may come at the expense of side effects such as memory loss or headaches. So depending on the situation, we may recommend starting off with 1 or 2 of these therapies and saving the third for if or when the tumor starts to grow again. Now you're probably asking yourself, if IDH mutations cause tumors, can we target them with treatment? And I'm so glad that you asked them, because we now have close within our grasp something called IDH inhibitors. The 2 agents that show the most promise in terms of how well they control tumor growth while minimizing side effects are ivosidenib, which blocks activity of IDH1 enzyme, and vorasidenib, which blocks both IDH2 and IDH1 enzymes. While neither are considered standard of care, ivosidenib in particular might be obtained off-label. And what that means is we might need to jump through some hoops with an insurance company to get access to this agent. And insurance companies tend to restrict access. So in very specific cases where it's appropriate, we may be able to get this agent. Vorasidenib is currently under investigation, but earlier this year it was granted priority review with the FDA. So we're all crossing fingers and hoping for good news soon. So what do we not know that we hope to know in the future? IDH inhibitors are fairly new, so we might still learn some more about long-term side effects and durability, which is basically another way of saying how well they keep tumors under control, and also how long does one need to stay on that medicine in order to control the tumor. Another frequently asked question is, when do you start a particular treatment? In some cases, we might need to start all 3 modalities at once. But for example, if it looks like a low-grade IDH mutant tumor has been removed, do we need to rush to radiation or chemotherapy? And the answer to that will vary from person to person, because the honest answer is that it's related to, the best treatment is related to what offers the best tumor control while minimizing the side effects. And finally, sometimes it feels like whack-a-mole when treating these tumors, because we find a target, we block it, and then the tumor finds a way to, around that treatment, to grow again. And so that's why there's a need for multiple strategies and newer strategies. And I'll end there. And I'll let Dr. Glass tell us about how we can find newer treatments through the process of clinical trials.
Okay, I found my unmute button. Okay, so we're going to talk about clinical trials. How do we apply what we've learned with regard to sequencing to clinical trials? So just no disclosures here. Just I don't know if I need to do that. So Dr. Alnahhas and Dr. Martinez spoke about various types of mutations that we can see with brain tumors, but there are a good number of mutations that we can target. So just as a background, we use clinical trials as a basis for all of our treatments, and everything that we discuss has gone. Yeah.
So sorry to interrupt, but are you sharing your screen?
I am sure. I'm supposedly sharing my screen. What are you seeing?
I see us.
Okay. I'll try this again. It says, okay. You see it now?
There we go.
Okay. All right. So, okay. And what are you seeing? Okay.
Disclosures.
Disclosures. Okay, perfect. Okay. All right. So, so like I said, no disclosures. And everything that we do in neuro-oncology, is based on evidence garnered from clinical trials. I just wanted to mention that a lot of what I'm talking about is listed in the NCCN, the National Comprehensive Cancer Network guideline for central nervous system cancers, which contains information regarding systemic therapies that have been shown to have at least some level of evidence in treating brain tumors. So just to run down clinical trials very quickly, phase 1 clinical trials are usually open label. They're open to a variety of cancer types and really are meant to test safety of a particular medication. We use the phase 1 study sometimes to see if the drug is actually getting into the tumor. Phase 2 studies evaluate for safety and preliminarily effectiveness. And these can be open label, single arm or randomized trials. Phase 3 trials are usually randomized. They may or may not be blinded and measures effectiveness of the study drug against either a standard of care or a placebo. There's also a phase 4 that's post-marketing. Okay, so just to give you a little history, so all of our current standard of care is, let's say for glioblastoma, initial treatment of glioblastoma comes from clinical trials. Back in the 70s, we established that radiation was effective. In the 80s and 90s, we established that maybe adding another medicine called BCNU was helpful, both in the form of intravenous drug, oral drug CCNU, or actually implantable BCNU wafers that went into the tumor at the time of surgery. Getting into the 2000s, we learned that temozolomide was of significant benefit. And in the 2010s and beyond, tumor treating fields were found to be of benefits. And these all come from well-performed, more or less rigorous clinical trials. And likewise for low-grade tumors, oligodendrogliomas and astrocytomas, we've learned a lot from clinical trials. So yeah, so recurrent disease, we haven't made as much progress, particularly with glioblastoma, but with others, we've seen some benefit from tumor resection, maybe some benefit from tumor resection, at least in terms of symptom management from interstitial chemotherapy, gliadol wafers or BCNU wafers, bevacizumab or Avastin, reirradiation, other chemotherapies and targeted therapies. So with regard to targeted therapies, there are a variety of forms of treatment that we can provide based on what we see. So when we sequence in-house, we're not really testing for all of what we can test for, what we call actionable mutations that we can treat with targeted therapies. So for example, I think we test for BRAF, but we may not be testing for others. We're testing for IDH mutations. So the NTRK gene fusion tumors, we have targets for those, what we call BRAF mutations, BRAF 600, V600E mutations. We can treat with a combination of BRAF inhibition and MEK inhibition, so usually a combination of two drugs, like the brafenib and trametinib. Fusions, we can treat with a different type of, we could treat with selumetinib, and for things like PD-1, PD-L1, PD-1 and PD-L1 mutations, or for tumors that have microsatellite instability or mismatch repair deficient tumors, we can treat with pembrolizumab, and pembrolizumab is FDA approved for that particular indication in any solid tumor, including glioblastoma. It's not very common in glioblastomas, but that's and it's something we don't test for in-house, but we do get this information from sending out to an outside lab such as Caris or Foundation One. And of course, isocitrate dehydrogenase inhibition, which Dr. Martinez just discussed using ivosidenib or vorasidenib. And ivosidenib is actually in the compendial in the NCCN, meaning it's recommended by the NCCN in circumstances, in particular oligodendrogliomas that come back, grade 2 oligodendrogliomas that recur. So we do have targeted therapies that are sort of standard of care because they're recommended by the NCCN guidelines. Yeah, I had a section on immunotherapy here, but this doesn't really go into what we're talking about here. So we do. So I will finish this up and then give us about 20 minutes for questions. So basically, we're always looking for new drugs to target mutations, and we're looking for mutations to target. And participation in clinical trials is important, as that because it helps us push the envelope. So I will move. I would say, I know we have a lot of questions. I think we should move on to those. So I'll turn it over to Dr. Martinez.
Right. So I'm going to start with some questions that are in the chat. The first question is, has any molecular profiling been done for schwannomas? And yes, they've actually, when I say they, I mean scientists that are much smarter than me, have identified mutations in NF2 and something called SMARCB1 as associated with the development of schwannomas. But it's a rare condition, so the understanding of that entity is still under development. All right, another question is, with respect to meningiomas, where do they fall into the normal cell versus malignant cell division slide? Are they sequenced the same way as malignant tumors, and how does sequencing impact their treatment post-surgery? Do you want to take this one, Dr. Alnahhas?
Sure, yes. So yes, I know our talk so far has been really focused more on gliomas, malignant tumors. But actually, meningiomas are the most common brain tumors, period, in adults. So when it comes to any brain tumor, whether it's benign, malignant, a lot of us end up having them. And sometimes they go undiagnosed because sometimes they can be small, really don't cause symptoms. So especially, say, early autopsy studies, when they started looking at meningiomas, after people pass away, we realized that actually the prevalence or how frequent they are is a lot more than we knew, just again from diagnosing. Time really meningiomas in 90-95% of the time, they are considered benign. So they are considered what we call grade 1 meningiomas. So they're really not cancerous in essence. However, their problem happens when they grow slowly over time, and then finally get to a point where they're either pressing on some important structure in the brain, or causing irritation or swelling in the brain, or seizures, perhaps sometimes pressing on, say, the optic nerves, causing things like vision loss. So that's when the issue starts happening, because of their size or because of their proximity to something that is important in the brain. So in meningiomas in general, the management has really been between surgery and radiation. The reason that systemic therapy, things like chemotherapy, has not worked very well for meningiomas is that chemotherapy really tries to kill cells that are very rapidly dividing, which is what cancer cells do. However, when it comes to cells that are very slow growing, such as in meningiomas, chemotherapy, things like chemotherapy, do not work as well. So that's why really surgery and radiation have been the mainstay of treatment for meningiomas. However, every now and then, unfortunately, some people may go through first surgery, second surgery, sometimes third surgery, first round of radiation, second round of radiation plus, and unfortunately, the meningioma keeps coming back. And it's one of these very tricky tumors, just because, again, beyond surgery and radiation, we're somewhat limited in terms of what can be offered. So this is where, back to the concept of targeted therapy, back to the concept of sequencing mutations, this is where meningiomas actually have been analyzed quite well, similar to the malignant tumors. And like Dr. Martinez mentioned with schwannomas, actually, so there is the most common mutation in meningiomas is what we call NF2 mutation. that sometimes happens just in individuals, what we call the somatic, again, that random event that just happened in one person, or sometimes can be familial, what we call the neurofibromatosis type 2 syndrome, where multiple generations of the family members can actually have meningiomas and schwannomas, actually. So now, because we understand these mutations better, there have been some clinical trials in the past 5 years or so that are trying specific targets for each of the common mutations that happen in the meningiomas. So one big trial that's happening is based in what we call the Alliance Consortium, which is a consortium of multiple cancer centers, and they're trying different agent for each meningioma depending on what mutation it has. For example, at Jefferson, we are part of a clinical trial that is specific for meningiomas that happen to have the NF2 mutation. So these are always happening, and again, we're always in the looks for new treatments, like Dr. Glass mentioned, new targets, as well as new treatments that are targeted, that commonly can have less side effects than something like chemotherapy that tries to kill anything that is fast growing.
Excellent answer. Is tonight only about cancers that are tumors? No, not necessarily. Mutations affect affect all cells, and they can lead to tumors that grow slowly, which are generally considered benign, or result in tumors that grow very fast and spread, which we consider to be malignant. And sometimes there's a gray area where it looks like something is not doesn't have characteristics of a fast-growing tumor, but will keep coming back. And those are some areas of interest because we want to prevent them from coming back, even though they generally look benign. Okay, so next question. Is it possible to target tumors with personalized medication or solutions as opposed to generalized medication?
I can answer that one because the answer is yes. If we know the genetic makeup and we see a mutation that we can target, absolutely we can personalize treatment based on that.
So we have a question about IMVAX. How does IMVAX work? So do you want to take this, Iyad?
Sure. So I think actually Dr. Glass had a slide about immunotherapy, but didn't go there. But so immunotherapy is this newer modality, just like we discussed, surgery, chemotherapy, radiation, these big modalities in cancer treatment. Immunotherapy was introduced, say, in the past decade or so, and it really revolutionized a lot of treatment for tumors, especially, say, for example, a cancer such as melanoma, whereas traditionally nothing really worked that well, and then came immunotherapy, and all of a sudden it really changed the trajectory for melanoma and treatment for melanoma. So immunotherapy is a big umbrella term. There's a lot of different things that fall under immunotherapy. There's a lot of different subtypes of treatments. So again, Dr. Glass hinted to some of that in his last slide. But the more kind of the wildly available treatment that is FDA approved for immunotherapy, is what we call immune checkpoint blockade. So the immune system, the cancer cells try to trick the immune system, so to speak, in that they say, okay, I'm part of the normal body, I'm not something that you should come and fight. And that's by expression of certain markers. For example, the PD-L1 marker is one of the most common, what we call, again, these immune checkpoints. So the cancer cells try to evade the immune system by expressing this PD-L1, and then they interact with the lymphocytes and they convince them that they're part of the normal body. So what these medications try to do is to try to take that interaction away. So they block that PD-L1, PD-1 interaction signal. And by doing that, they stimulate the immune system to go and find the tumors. So medications such as Opdivo, or known as nivolumab, pembrolizumab, all these medications, that's the essence of them. And they've been tried in the setting of glioblastoma. They've been even now, and they are currently in trials for things like meningiomas even. However, it's still been a little tricky for things like immunotherapy when it comes to the brain, because it has been kind of accepted, although the brain is an immunoprivileged site. That means that it kind of is separated some from the immune system, although this is now changing, but it's still somewhat of a challenge for immunotherapy to actually get into the brain and work well for the brain. There are certain situations, and a lot is changing in our understanding for how this immunotherapy works, and specifically how it works for brain tumors. So this is immune checkpoint blockade. A different subtype of immunotherapy is what we call vaccine. And there are different vaccine strategies. The simplest approach is, you take a piece of the tumor, you take some immune cells from the blood, and then you educate the immune cells about the tumor cells by putting them in the lab. So by kind of exposing the immune cells to the cancer cells, say in something like a petri dish, and then finally you kind of process them and put them back in the body. So that's kind of where MVAX, the idea of MVAX happened. So the idea is to, again, take some of the cancer cells, radiate them so they're not active anymore, and that also helps them kind of expose all their material out. And then you put them all together with the immune cells from the same individual, and then you transfuse them back to the individual. In the case of MVAX, they put them actually in cassettes that go in the belly. So that's kind of the concept. It's kind of a vaccine in essence. There's a little more details that go into it. But these vaccines have been tried before, and MVAX just has a kind of a more of a fresh approach to things in terms of specific targets. But there certainly have been other trials for vaccines in glioblastoma and other tumors. And MVAX is actually close to finalizing their recruitment. So we're hoping to get some results from MVAX in the very near future.
Thank you, Dr. Alnahhas. All right, so there's a question about someone has a brainstem glioma present for over 20 years. She gets checked regularly, had previously chemotherapy and radiation. The question is, can her tumor grow back? 20 years is a long time, and so that's actually optimistic, although, there's some information that it would be helpful to know before, we can make a better prediction, such as, again, the tumor profiling can have some impact. But I don't know if Dr. Glass or Dr. Alnahhas have any insights.
Obviously, it's dependent on what it is. Many times we cannot get a biopsy of these. We make assumptions based on what it looks like. But sometimes these are what we call midline gliomas, or which are very, very aggressive. And sometimes they're not. Sometimes they're just low-grade astrocytomas or oligodendrogliomas, which will go more along with doing well. So we need to know what that is. But any tumor can grow back, and continued monitoring is always needed.
Yeah, I would agree. It's very true. Right. Does vorasidenib or ivosidenib work for grade 4 astrocytoma, that's IDH mutant, or does it only work for low-grade tumors? So far, the response to that high-grade tumors have with these agents is, mixed. There are a few case reports of higher grade tumors responding favorably to ivosidenib, but the question is, how long does it last? Because the thought is tumors that IDH mutant astrocytomas that have progressed to grade 4 have some other insult, some other genetic mutation that is causing rapid growth. So it's not, there are other things that we have to take into consideration. right now the ivosidenib is approved for IDH mutant astrocytomas. You can try it on, possibly you can try to make a case for grade 4 astrocytomas, but the focus is actually on lower grade tumors because that's where we've seen the best results. Next question. Can a tumor that's left untreated for too long turn into glioblastoma or have the grade become more severe?
So the answer there is, it is yes. Both, I looking at just at gliomas, both the IDH mutant and IDH wild type can evolve to a grade 4 tumor. Now, when we use the term glioblastoma, this refers only to IDH wild type tumors, but IDH mutant tumors can become grade 4, and all tumors can advance in grade. And that's regardless of treatment. Even treated tumors can progress to a higher grade.
I have another question. Are brain tumors generally hereditary?
Okay, well, I can answer that. Brain tumors can be predisposed to in patients who have germline mutations or who have syndromes in which increase the risk of cancer, but this is an association with other cancers. So yes, they can be hereditary along with other cancers. Much more commonly, they're sporadic, meaning they occur without a significant family history of cancer. And I usually recommend genetic testing if there's any question. If patients have a decent number of cancers in their family, I usually send them for genetic for a geneticist evaluation by a geneticist, or just send off just testing for germline mutations.
I will add to that the best known germline mutation associated with familial gliomas is POT1, and I am not aware of any others, but it's extremely rare, and there's usually a very clear genetic predisposition, meaning somebody from with a first-degree relative has a glioma or the same diagnosis, and those we need to be cautious with. Okay, I have another question. What are the known causes of brain tumors and how do we prevent tumor growth?
So again, unfortunately, we haven't been able to identify really any risk factors necessarily for brain tumors. The one risk that we actually do know about is radiation. So sometimes, say kids with leukemia, sometimes they get radiation pretty much to the entire body, and then hopefully if they survive that, but sometimes, decades down the line, say 2 or 3 decades down the line, they may actually start having tumors. They may be brain tumors, they may be benign, such as meningiomas, or they can actually be gliomas. So that's the one thing that we actually do know about, but short of that, unfortunately, still, again, we don't know of any risk factors. And as many of you know, we don't really have screening for brain tumors, whereas we have screening, say, for colon cancer, we have screening for breast cancer. We don't have screening for brain tumors because, in general, they are considered rare. So if you're trying to implement like a nationwide policy, it becomes really not very realistic to do something like that. But of course, this is an area still of active research, so who knows what the near future may hold and give us some answers.
Great, and I think we have time for one more question. Does the Jefferson Neurosurgery Department offer services to address the mental health component of patients coping with a brain tumor diagnosis? We are very well connected, even though the panelists here are focused on treating tumors. We work in conjunction with the neurosurgeons and the radiation oncologists, but we're also very well connected with the supportive medicine cancer survivorship group. They can assist with coping with day-to-day challenges. The neurosurgery department also has a social worker who is fantastic. We also have a social worker associated with the cancer center. And they also provide emotional support beyond what the rest of the team also provides. But they can also connect you with specialists, therapists, psychiatrists if needed. So although we don't have a therapist psychiatrist that's associated directly with Jefferson Neurosurgery, we know people, we have connections, and we can help you find them. Okay, so we've got 1 minute left. I want to thank everybody for joining. I want to thank the panelists. Also want to thank Sean Mitchell for helping put this together. I hope everybody learned something, and please keep the questions coming, and we'll see you around.
Thank you all for joining.